acquisitions with magnetic resonance imaging, or MRIs, that are becoming more widely available, and some of the modalities that have more standard sequences that are available on the scanners themselves, which require less local expertise in certain areas. In general, why people would be interested in neuroimaging as a biomarker of central nervous system disorders, it provides us a second window, or third, in addition to neuropsychological, neurobehavioral, and psychiatric feedback about potential biomarkers of injury that's non-invasive, can take a look in very different ways at the brain. So we hope through neuroimaging we can better define the neuropathogenesis of HIV, to monitor disease progression and change over time, to enable more accurate diagnosis or identify individuals that are at risk for perhaps future cognitive problems or upcoming changes in their performance, and to guide treatment is where we're heading, to guide treatment and monitor therapeutic intervention. MRI, as I mentioned, is allowing the study of HIV-related effects on brain structure, on metabolite concentration, and white matter integrity. There are also other measures, of course, of cerebral blood flow and functional MRI, but I'm not going to touch on those today. Some of the questions that we in the field are looking at is what neuroimaging can tell us about the impact of HIV. What are the common characteristics of neuropathogenesis in the current era? How much has it changed with the advent of antiretroviral therapies? And we are seeing there still is impairment in the brain, even in the current successfully treated individuals. What is the role of the history of severe immunosuppression? If we let the nadir CD4 count get too low, what kind of permanent damage or tissue loss might they be experiencing? How does the brain respond during immune recovery? Is there any impact on how the brain's response would affect cognition or functional performance? More broadly, there are also in studies of psychiatric or other comorbidities, what's the combination of HIV and other disorders? Would that increase the likelihood of brain injury in some individuals? And can patterns of abnormalities help us classify those at great risk for cognitive decline over time? So these are just a sampling of a lot of the work that's being done in the area, and of course there are a lot of other questions as well. This is a graphical representation of some work we've done in the Charter project that was mentioned earlier. This is a national study in the United States where we have 5 neuroimaging sites looking at a few hundred individuals at baseline as well as over time. And this is a sample where we just looked at approximately 75 people over a year of time to look at decline. This is a very simple estimate of change, what happens from time point 1 to time point 2, without accounting for a lot of other important variables. But it gives you some idea that there is white matter damage. This is a significant loss of total volume of white matter, and an increase, rather dramatic one, of abnormalities in the white matter, which I'll explain again in a moment. But it suggests that even in the current era of treatment, we have over time white matter damage that's accompanied by an increase in ventricular volume or cerebrospinal fluid, which is supportive of an atrophy model. So one of the questions we had, I said this is a very simplistic look at change over time. There are a lot of factors that we need to account for. We know that age, for example, as we get older, we have tissue loss. You also have issues related to the different scanners. We're using 5 different scanners in this site. Gender, a lot of other influences in addition to comorbidities are important to account for. Here is a multivariable analysis where we included nadir CD4 as well as a number of other variables to look at this change effect over time. We found that, not change, this is just a cross-sectional study. So looking at what is associated with loss of white matter and increase in abnormalities as well as an increase in fluid space was significantly associated with nadir CD4, suggesting that if we allow people to go too far beyond, we'll have permanent damage that will stay with them over time. So as I mentioned, there are a lot of different factors associated with brain alterations. I mentioned age, which is a big one, especially as the HIV population, those with HIV are continuing to live longer and get to an older age where a lot of structural as well as functional changes are occurring in the brain. There are a lot of ongoing studies looking at the influence of genetics, the association of cognition. How is that related? What's the impact of these, the brain injury that we're assessing? Psychiatric, metabolic, immune status, as well as treatment effects and the association with CSF biomarkers are all studies of areas of interest. So I'm going to talk to you about three very common, more common MRI modalities, some of which are available on standard MR scanners that are across a variety of vendors, becoming more available in international settings as well. What most people think about first off is anatomical or structural MRI, where we can look at structural size and volume of both the tissue and the CSF spaces to get an assessment of tissue damage or loss, and we can even measure inflammation, so changes that might be occurring in the white matter. There's also MR spectroscopy, which HIV field has done a lot of work in spectroscopy to sample metabolite levels to assess neuronal integrity and inflammation, as well as more recently diffusion tensor imaging that's looking more at the white matter fibers, as I've shown you that HIV has a significant impact in white matter. So I'm going to talk briefly about each of these three more common modalities and some of the current findings in HIV. Whoa. This is an anatomical imaging, three different sequences that are fairly common. This is called a T1 weighted image, and it's probably hard for you guys to see from back there. Got a little stretched out. There you can see the cortex versus white matter. There's very good contrast there. You can get very good information about the thickness of the cortical ribbon. T2 weighted images here give us information about the fluid spaces. So we can, how big are the ventricles and how much fluid are filling the subarachnoid or sulcal CSF spaces. And the proton density weighted image we like in HIV in particular gives you better information about some of the subcortical or basal ganglia structures that are important in HIV. Here's one example, and there are many ways to analyze your structural data. This is a multi-channel approach that uses all three of those sequences to get some estimates of global structural changes. We have, for example, I'll start with cortical gray matter here in blue, subcortical gray matter. This is the basal ganglia. We have the caudate and the putamen. We have white matter. We also get ventricular and sulcal fluid spaces. This is a section approximately one in the back and one in the front looking coronally. And then we have these bright yellow markers, which we call abnormal white matter. It's a change in the water content in the white matter that can be due to a variety of reasons, from demyelination to gliosis. We believe that what we're seeing, at least in some cases, is inflammation in HIV, although there are a lot of different, I won't go into detail, but there seem to be different subtypes of these abnormalities in the white matter. And broadly, the literature suggests basal ganglia and white matter damage in HIV. The white matter pathology, there's volume loss. Even in current era of individuals on treatment, we still have loss of total volume over time, and that has been associated with detectable HIV CSF RNA, viral load, as well as having a lower nadir CD4. You also see this increase in these white matter abnormalities are associated with lower nadir CD4, as well as some postmortem markers of dendritic loss. We also have some basal ganglia damage has been common throughout the study of HIV and still is today, primarily caudate atrophy, as well as just general subcortical volume loss. And that also has been associated with a lower nadir CD4 count and has been associated with neurocognitive impairment. More recently in the Charter study, it's some work that Dr. Ranellis is going to present at the next meeting, where we've seen some changes over time. Again, that shows abnormalities that are linked to individuals with increasing CD4 counts during recovery while they're on effective antiretroviral therapy. So this is a schematic representing change over time. It's approximately 1 year on average, where those individuals who have a CD4 count that's increasing by 50 points or more are in red. Those who have decreasing CD4 counts of more than 50 points are in blue, and those in the middle are in this gray, sort of unchanged estimate. And you can see that those individuals who have an increasing CD4 count have an increasing amount over that year span of these abnormalities in the white matter, as well as an increase in total volume of subcortical gray matter, and less change in their CSF spaces, whereas those individuals with unchanging or decreasing CD4 count are having an increase in their CSF volume. So we're exploring this as a possible inflammatory response during immune recovery. A second modality that's very commonly studied in HIV is MR spectroscopy, and it gives you measures of metabolites. You take samples in certain locations of the brain, and you can measure, for example, N-acetyl aspartate, or NAA. That gives you some information about neuronal integrity. You can measure choline at this peak. You get some information about cell membrane degradation and lipid changes, or myeloinositol, glial proliferation, or inflammation, as well as some creatine measures of energy stores. A lot of work has shown, has emphasized the NAA and the choline and myeloinositol markers of neuronal integrity and inflammation. There are three regions that are commonly sampled in the study of HIV, and I'm showing them to you here on an axial slice. This axial slice is slightly lower, this one slightly higher in the brain. And we have down here an attempt to assess basal ganglia, metabolites in the basal ganglia, and more superiorly, we assess frontal gray matter and frontal white matter areas that are thought to be affected in HIV. Broadly, as well as within the Charter study, we see decreased neuronal integrity and increased inflammation in HIV. The neuronal injury is evident by reduced NAA, and this also may be associated with decreasing current CD4 count. This is a schematic where we have the rate of annual change. So over time, what happens to your NAA markers in these three different regions I showed you? In the frontal gray, basal ganglia, and frontal white matter, we have consistent, significant decreases in NAA over time in these individuals who are mostly on antiretroviral therapies. We also have some suggestions of higher levels over time in the choline and myeloinositol, which suggests inflammation, perhaps, that even in individuals that may be predicted by inadequate vital suppression in CSF at baseline. And finally, I'm going to talk to you briefly about diffusion tensor imaging. This is a technique that's not as widely available as the first two, but is becoming more so and more standardized across vendors as well. In diffusion tensor imaging, we're trying to quantify the motion of water molecules, and one of the common metrics you'll read about in the literature is a calculated fractional anisotropy, or FA. It's a scalar value of the degree of anisotropy and the directional variation of the water. And most people are looking at this in white matter. Here's the schematic of what's happening in CSF. As you can imagine, water is simply diffusing fairly equally in all directions. And you can represent that in a sphere. You have radial and longitudinal axes that just tell you, that the water molecules are simply going around in a circular direction. But what happens in particular in myelinated white matter fiber tracts is you have a much more of a ellipsoid shape because you have a longer flow. There's a more directionality in the diffusion of the water molecules along the white matter fiber tracts. And so what we can assess in diffusion tensor imaging is changes in either the longitudinal or radial components, which then can be calculated as FA to see how HIV may be affecting the structural diffusion in the white matter. Alterations in the white matter integrity will modify these diffusion properties and thus the metrics we're measuring. Here is an example using a program I'll mention in a little bit called tract-based spatial statistics. What it's trying to do is look at the most common and strongest fiber tracts in the brain and assess the, for example, FA in this image. And in HIV, it has been shown that you can get either FA increases or decreases depending on the study and the area of the brain. So this is a bit complex in many disorders, but also in HIV because, as you can see, there are certain areas where the fiber tracts are much stronger and easier to assess directional variation. Other areas of the brain For example, back here you have a lot of crossing fibers. We've all seen pictures of white matter fiber tracks, and it's very difficult to find exactly where they're going and what happens when the fibers cross. So assessing the differences between HIV and controls, our sensitivity is greatest in areas where the fiber tracks are most dense. So what we've seen so far in studies of HIV, we do see reports of altered FA that support white matter damage in various regions of the brain. But again, it's a more complex picture depending on the area, the type of fiber tracks, and how many tracks are crossing in that area. Altered FA has been associated with neurocognitive impairment as well as current CD4 levels and HIV viral load. It's also true we've been starting to examine DTI in the caudate and putamen, as we know these regions are affected in HIV, and because the caudate and putamen have more vasculature and more white matter fibers running through them, you can get some decreases in FA in these regions relative to control subjects as well. So back to what we were learning about some of the initial exploratory questions that I brought up to you earlier on in this presentation. We have learned that white matter and basal ganglia injury remain common, even in the current era of treatment. And there's evidence of both neuronal loss and inflammation. We have also found preliminary evidence of a lower CD4 nadir is associated with tissue loss, reduced neuronal integrity, and white matter damage. We have some suggestions of inflammation in the white matter and in subcortical gray that are being explored in association with cognition. So are these potential inflammatory responses that we see on imaging with an increase in CD4 affecting cognition or any functional performance? We also have a current study looking at an interaction between HIV and psychiatric history, studying in South Africa with Dr. Soraya Sidat, whether there is a severe trauma influences the presentation of HIV in the brain. Does the history of trauma impact your immune system? Are there interactions? Are the effects of HIV in the brain worse in that particular context? And there's also a broad interest in predicting cognitive decline to ensure timely treatment. Now I'm going to briefly shift gears just to tell you what you might want to think about if you're interested in doing MRI in your area or collaborating with someone doing so. We have, as part of the HIV neurobehavioral research program in San Diego, we have a number of preliminary studies in international settings with South Africa. We're exploring preliminary data with some folks in Romania, as well as India and China, trying to get some more collaborations going and work done in those settings. Magnetic resonance imaging to a lot of people sounds very complicated, and it used to be even more so. The MR physics or sequence development experience used to be highly important at the local setting, but now a lot of the vendors that are selling the scanners have incorporated standard sequences that can be used in a variety of techniques. So the acquisition of data has become a little bit more attainable in many settings. There's also the components of computational knowledge and image analysis, as well as validation of the methods in your particular population, which has become important, as well as the clinical knowledge and the biostatistics important in the data analysis. As I mentioned, a lot of this expertise in MR physics and sequence development, while though important, is helped by the fact that the scanners are coming with these standard sequences and making it easier for individuals to acquire data in the local setting, even if they want to collaborate more broadly with people with more expertise in those areas. The computational knowledge, if you are interested in analyzing the data yourself, you have to be comfortable with computers, but there are a lot of image analysis methods that are also available on the web now, freeware, that people are making available to do your own analysis or to collaborate with other folks. I'm going to highlight methods of validation just for a second because it's important to understand your cohort and the differences there might be from where those methods were developed. For example, we're doing some of the diffusion tensor analysis in the South Africa study, and we have found that the atlases that come with the tools that we're using are not appropriate because simply the shape of the head and therefore the shapes of the brain are different in the cohort of individuals we're looking at in South Africa than in the group that was used to make the atlas in the UK. So we've developed our own atlas to use in that environment. So it's just important to keep in mind that we have a lot of individual variations as we do in our educational attainment or socioeconomic status. Our brain morphology can be different across different racial groups. So locally, one thing that we suggest if you're assessing the capabilities of an MRI that is near you would be to define what the vendor is in the operating system, the field strength, at least a 1.5T, which is very much more common now than it used to be, is good for getting good resolution in the brain. The use of a head coil is fairly important. The 8-channel head coils are coming with most of the new units that allow you to get good resolution in the brain as well. And then you want to assess what are your capabilities of the scanner you have. Most scanners come with anatomical and even spectroscopic capabilities now. Diffusion tensor or echoplanar imaging, which would also include functional MRI, may or may not be something that you could do locally. And then what sequences are available, what kinds of T1s and T2s, and some scanners may have research possibilities, but a lot of these standard sequences now are useful in determining the information we were just discussing. And then if you're interested in doing image processing yourself locally, you need some computational expertise and some equipment, although even that is becoming more attainable by the day. And there are also a lot of individuals interested in collaborating with folks, so that's something we can also help you with. So some of the anatomical methods, this whole slide is about structural imaging. There are many different ways to approach it, many different ways to get information about the cortex, or if you're more interested in the basal ganglia. I have some references for people interested in the different kinds of methods. You can use just the T1 weighted image, particularly if you're interested in the cortex, or you can use multiple sequences to get more information about the white matter and the basal ganglia. For spectroscopy and diffusion image analysis, LC model is a common tool used for spectroscopy. Diffusion is more on the cutting edge of image analysis approaches. There are some track-based spatial statistics that I mentioned to you that are freely available, and there's some more complicated fiber track mapping that are attempting to define these large fiber tracks, which fibers are crossing, and that's really on the early edge of research at this point. So some of the resources that are available to folks are at the HNRC, where we have an international core that supports our consultation for exploring neuroimaging capabilities, and our work is supported by the HNRC and the Charter program. Thank you. Are there any questions?